I first encountered Dr. Asif Ali caring for a functional medicine patient who brought in probiotics and other supplements. As I explained to her why I'd recommended that she use them, I noticed an uncomfortable look cross my patient's face. And then I asked, wait, did I give you those supplements? And she said, no, my cardiologist did. I was instantly intrigued and impressed. When I asked who their cardiologist was, I discovered it was Dr. Ali, someone I had actually worked with during residency. He was covering the cardiology service one weekend, teaching us how to care for patients with heart disease and abnormal heart rhythms and other issues, and he left an indelible impression on me. Heart disease remains the leading cause of death in the United States, claiming nearly 700,000 lives each year. Millions more live with high blood pressure, clogged arteries, and other cardiovascular challenges that quietly erode their lives. In functional medicine, my focus was always on uncovering the root causes of disease, not just treating symptoms. Today, we're bringing that approach to one of our most vital organs in your body, the heart. Joining me, Dr. Ali is a renowned cardiologist, clinical associate professor of cardiovascular medicine at the University of Texas Medical School in Houston, and partner at Houston Cardiology Consultants. He's an expert in advanced cardiovascular imaging, serves as chief medical officer and chief of cardiology at several Houston area hospitals, and sits on key committees for the American Heart Association. He has authored medical textbooks, published widely on cardiovascular disease, and shared his experience on national outlets, including The Dr. Oz Show, Fox News, and local media. In this conversation, we'll explore how America reached this heart health crisis, uncover the hidden drivers of cardiovascular disease, and discuss what can be done, not only to prevent heart disease, but to begin reversing it. Prepare to hear the truth about what's really driving cardiovascular decline in America, and learn actionable steps to protect your heart and reclaim the vitality that you deserve starting today. Dr. Ali, thank you so much for joining me. I'm excited to speak with you.
And thank you so much for having me.
Yeah.
And I love the context, what you just said, starting today, because everyone can do something starting now.
Heart disease is responsible for over 700,000 deaths per year in the United States, making it the country's #1 killer and health crisis that touches millions of lives. How has the prevalence of heart disease changed over the last few decades? With all of the advanced technology and medical innovation that we have today, what's behind the persistently high burden of heart disease, and why can't we seem to escape this cardiac grim reaper?
Wow, what a title about cardiac. And it really is the #1 killer. I want to make sure we talk about genders as well, because it's not just males, it's females as well, with breast cancer being a close second. And I think to answer your question, we have to go back and look at McGinnis and Fogarty. So these were two individuals at the NIH, at the National Institute of Health, which is kind of the area we look at the CDC, Centers of Disease Control, and the NIH is two big epicenters in America in the government that looks at causes of disease. So the effect is heart disease, heart attacks, death. So we have to go back and look at the cause. And what they looked at in every 10 years is what is actually the cause and what is the effect of death in the US, with heart disease being the first. And what they went back, and so we can even go back to the year 1990, then in 2000 and 2010. So I've been reading these every decade, kind of where America's society is going as far as cardiovascular death and other deaths as well, by the way. And what they found is the effect is cardiovascular death, but the cause is things like what we're eating, smoking, obesity, lack of exercise. So these are the drivers that then cause things like diabetes, hypertension, kidney disease. So it's called cardiometabolic renal. So that's heart. Metabolic is obesity, diabetes, and kidney. And these are now all linked. And these are effects of the things that we're doing in our lifestyles, including your genetics, including something called epigenetics, which is how your environment influences your genetics, and then your environmental and day-to-day decision, which also includes your sleep.
I love that what you answered was genetics and lifestyle. How much of heart disease comes from genetics versus lifestyle?
So we're learning more and more about that every day. So just to give an example, we just talked about drivers of heart disease. So I'll talk about one, for example, high blood pressure. So that's called hypertension. So 95% of hypertension is due to something called primary essential hypertension, which is your genetics. Yes, your salt. Yes, your sleep. Yes, your weight. Yes, your lack of exercise and stress, by the way. Mental health, we need to make sure we address that because that is a very much a driving force today with Americans. We're all under stress one way or another. Just driving here in traffic, definitely put me into a sympathetic heightened state. But I love talking about this, so I'm good now. But those are things that we have to really address, and it is not just one driving force. It is this culmination of all of these forces that really translate into cause and effect.
Hmm.
And these are things that we can work on. Like you said in the beginning of this conversation, what are going to be some take home messages? It's going to really revolve around your day to day decisions and
Hmm.
how we can put things into practice to help you mitigate heart disease.
I love that you're touching on stress as being a driver contributing to heart disease. I had an experience in medical school where our cardiology professor had us take our pulse and then do a 5-minute meditation and take our pulse again. And across the board, everyone in the room had a lower pulse. So, it was proof positive that meditation and just relaxing could affect our heart. How many of your colleagues do you think are talking about this?
So there's actually a paper in the American Heart Association that looked at Tai Chi and meditation and definitely showed some positive outcomes. So I won't talk about my colleagues because I think, you know, and I hope we're all pushing towards lifestyle choices as the number one, not medications first.
Mm.
And in fact, if you look at most medications, line 1 and 2 actually first say look at the lifestyle choices of your patient. Address that first. It's not writing a medication first, it's addressing lifestyle choices. So I think we need to, even if you go back to the fundamentals, it's not just as simple as what you eat and how much exercise. I know we talk a lot about that. There's a lot of nuances even with that. But to answer your question about mental stress, it is something that we should be talking about more. And I'm saying not just stressors, but things that can cause mental stress, physical stress. You just said it, the heart rate's going up, and just a little bit of meditation, taking a few deep breaths, taking a pause, getting some relaxation in, being present, being focused. We do this a lot while we talk on our phones. If you're not able to see the podcast, trying to multitask, but sometimes just putting the phones away, having a conversation, having a cup of coffee or water or whatever your beverage is, and being able to tap into that parasympathetic, which is the relaxation state, is super important to do. And there's science that backs that up. And I think that's the important part.
It sounds like it's as simple as just being human again.
Absolutely. Getting back to the human side of things.
Um, as you know, and you said briefly before we started the podcast, heart disease does not discriminate, but certain populations are more vulnerable due to a combination of genetics, lifestyle, and other health conditions. Who is most at risk for developing heart disease and what makes them more vulnerable?
So, unfortunately, it's actually your zip code that is the greatest determinant of your healthcare outcomes. And that has been very played out. In fact, I've even published a paper around what's called social determinants of health.
Mm.
And social determinants of health are multiple factors, including your transportation, including childcare, including access to good, healthy foods. And even there's a term called cardiology deserts. So it was eye opening when I saw this when I was working on my master's in public health that 50% of America has what's called a cardiology desert. And a cardiology desert is defined as more than an hour round trip to go see a heart doctor. And what they found is if you live in a cardiology desert, which is 50% of America, your healthcare outcomes for your heart reduced by 31%. So almost a third impact of worsening of heart disease if you did not have access.
Mm-hmm.
So your zip code, your access. What does that mean, access? That means access to food. That means access to a safe neighborhood to walk around
Yeah.
and get some exercise. It means access to healthy, clean air and healthy, clean water. We know we've even had issues in
Mm-hmm.
Detroit
Mm-hmm.
around that. And it means having access to prevention and access to education and awareness, which I'm so glad you're doing this podcast because it is this education awareness. We're trying to empower patients to be the best that they can be with the resources they have. But we're also here to make sure we call out the inequities and inequalities that exist, and they're definitely there. So I think it's important to call those things out. But imagine that it is really your zip code, even over your genetics.
Wow.
Right. And having that inability to access in those cardiology deserts are super important. And so I think, hopefully people listening to this podcast, this is to really empower them with the knowledge to go back and seek more from their healthcare providers to say, look, I know I'm on a bunch of medications. And a call out to action here is to really talk to your physicians to say, I'm on a lot of medications, but in addition to this, yes, I do understand the importance of it, and please explain why I'm on every medication. I want to make sure that you have justification. But what are the things that I can do to prevent and get off of these medications? In some cases, we can do that.
Mm-hmm.
But give me the education and the knowledge and power so that I can do the prevention stuff while I'm doing the treatment. And when I look at wellness, I look at that like, what are the wellness things we can do in addition to the treatments that we need to do so that we can have that kind of combination and eventually really prevent heart disease.
Right. It's interesting. I've never heard of a cardiology desert. I've only heard of a food desert and a childcare desert with the same idea that within a certain radius of your home, there aren't healthy food options in grocery stores or childcare, what have you. But it sounds like the people who are in these deserts have multiple deserts that are layered on top of themselves. So, how do we fix that?
Yeah, so that's $1 million,
Yeah.
it's more than $1 million. It's a
Yeah.
multi-billion dollar, it's a
Mm,
$1 trillion. We spend about 17.4% of our gross national GDP. Uh,
mm,
That's 70% of every dollar that's going out, we're putting into the healthcare.
mm.
But yet in the US, we're not the highest level of prevention of outcomes.
Right.
We spend a considerable amount of money, but we're not getting the outcomes. So then we need to take a step back and think about that, right? If 17 cents of every dollar is going towards healthcare, why are we not the number one healthcare system in the world? And to answer your question, you said it very well. I mean, there is a lot of different types of deserts, but those deserts end up taking an impact on our health. And unfortunately, in lower socioeconomic status. So the paper is in barcode, but I did a study and I just published in the American Heart Association. It'll be presented in November. And what we did is we looked at all of our patients. We have offices in the north of Houston that are more Medicaid and Medicare. And then we have an office in West Houston, which is less Medicaid and Medicare. And we were very curious to see based on your zip code, what were the number of patients who had high blood pressure? What are the number of patients that had diabetes? What are the number of patients that had more heart disease? And what we found out were in those lower, and it wasn't a big surprise, but we wanted to actually look at that information. That statement that I said, your zip code determines your health outcomes. And we wanted to do that even in our own ecosystem. And what we found is by even having one social determinant of health issue, that could be having to take two buses to get to my office, that
Mm.
could be childcare issues, transportation issues like we talked about. not having enough money to get your medications, affordability, not having access to good, healthy food. So, what we found is even if you had one social determinant of health issue, the incidence of high blood pressure was higher. The incidence of diabetes was higher. The incidence of heart disease was higher. And so, what part of our project looking at population health, which is the population's actual outcomes and what we call health economic outcome research. We want to present this in front of the Houston City Council and to say, look, here's the real data. And if we don't, it's worth us putting money and resources into those cardiology deserts, into those people who don't have access, make it less expensive. Instead of a bag of chips for 99 cents, make a carrot
Mm,
an alternative. But don't make that carrot $5
right.
and the bag of chips, the alternative, something that's less expensive because ultimately the dollars we're going to spend to save that person eating unhealthy is going to cost us more in the long run.
I can imagine that someone listening who lives in these deserts and realizes that this is a $1 trillion issue to solve and that we're working on it, but they don't quite have those resources yet. What would you say they can do right now with the resources that they have to improve their cardiac health?
Yeah. So first of all, I think we're addressing the problem, right? So first we need to talk about, first we need to acknowledge it. So we're acknowledging patients have this issue. With acknowledgement comes ownership of it. So we need to address it. So we're addressing it here. We're talking about it. We're making it real because it's easy to sweep this off the side and not talk about public health issues. And then number two is, I really want to make sure individuals empower themselves just with knowledge, which is what we're imparting today, but talk to your doctor, see if you can get a social worker. Even medications have hotlines if you're not able to afford it. There's the county system. I worked at LBJ Hospital. I did all my training in the county. These were my people. These were the people I fought for every day to make sure they understood how to work through the system. Because part of it is just understanding what are your rights within the system and making sure that we tagged them to a social worker, make sure they knew what resources they had. I think part of it is just not knowing that there are resources out there. So, go to Harris County Medical Society, look at the resources that are available to patients. See if you can access a social worker. When you talk to your doctor, ask them, um, can I get a gold card? Can I go to, there's a clinic called Ibn Sina Clinic. They see people for free for their healthcare. They give them access to cheaper pharmaceuticals, for example. So part of it is just navigating the system. But if you don't even know it exists there, that's why I love these podcasts because you're giving that knowledge to the people who really need it and you're empowering them. So really appreciate you doing these podcasts.
Yes, thank you. And thank you for that information. I imagine that is potentially life saving for some people who are hearing this. Heart disease is a broad term that encompasses multiple conditions affecting the heart and blood vessels. Understanding what it is, how it develops, and how it is diagnosed is critical for prevention and early detection. Can you define what heart disease actually is and how it's diagnosed?
Yes, absolutely. So when we say heart disease, I want to really talk about cardiovascular because cardio means heart. So it's the same thing. So we could say heart vascular or we could say cardiovascular. So it's all the same thing. You have a heart, it's a pump, and you have blood vessels. And those blood vessels, basically your heart's a pump. It's supposed to push blood once it gets oxygenated from the lungs to the rest of your body. And so you have blood vessels from your head to toe. And so things that can affect your blood vessels from head to toe, including your heart, are things like high blood pressure, things like diabetes, things like being overweight, smoking. These are all risk factors for heart disease. So, what is heart disease? It is the actual slowing down or disease. It's a disease. It's actually a disease state in the blood vessels that can affect both your heart and any organ in your body, your brain, your heart, your kidneys, all the way down to your legs. And I want to point out even sexual dysfunction, like erectile dysfunction for males and even for females can have some sexual dysfunction because of a lack of blood flow. And it is that lack of blood flow which is heart disease. And
Hmm.
that is due to things like we just talked about, risk factors like hypertension and diabetes and obesity and smoking and
Yeah.
lack of exercise. That leads to slowing down of the blood in
Hmm.
your vessels. And when you have slowing down of your blood to your vessels, guess what? You're not getting the nutrients,
Hmm.
the oxygen, the the vital things that we need to survive. And when you don't get blood flow to your heart, you get chest pain. When you don't get blood flow to your brain, you get a stroke. When you don't get blood flow to your kidneys, you go on dialysis.
Hmm.
And when you don't get blood flow down to your feet, it's terrible, but we have to amputate
Yeah.
if we can't save them. So it is a lack of blood flow that causes all of this. And those are the risk factors that cause that.
Yes, thank you. You actually took away my next question, so you took the words right out of my mouth. You've always emphasized the importance of a good physical exam. I remember that when you covered the service when I was in residency, and that's something that I deeply appreciate. Since observation is the first step of any physical exam, when a patient first walks into your exam room, what are the physical cues or patterns you immediately notice?
Wow. So that's a great question. I teach this still to my medical students even today. Um, So when I first walk in actually into a room, I first look at actually the face of the patient and I'm looking
Mm,
at their eyes because I want to make a connection. And that's not more of a medical thing. That's more to just say, hey, I'm here for you. I'm
yeah.
acknowledging you.
Mhm.
I'm not going to gaslight you. I'm going to listen to your concerns. And I
Right.
have to do that in 0.2 seconds. And I have to walk in and you have to feel comfortable that I'm the right person
Right.
to talk to you. I want to acknowledge you. The second thing is there are actual physical signs, and these are very interesting signs that I look for. So one is a earlobe crease. So there's a crease called, and the name of it is called Frank sign, Frank sign. And what they found is if you have a earlobe crease, and there's 4 grades in your earlobe, so it's not about when you get your ear pierced, talking about an actual a crease in your ear, that is an indication for high blood pressure and diabetes and possibly heart disease.
Oh.
So you can Google Frank sign. Number 2 is something called xanthomas. So there, some you'll see it in around the eye lobes. It's actually cholesterol deposits that can form, and I've seen some of my patients put makeup and it's this bump on their eyelid and they're like, it just doesn't go away. And they'll even get cosmetic surgery around it. But the cause is actually high cholesterol. So that's a second thing. A third thing I can actually see is bounding pulses in the neck. That can be an indication for high blood pressure, not in all cases. And the fourth thing I look at is actually your hands. So on the hands, you can see your veins. And I'm drinking some water here. And so just to make sure everyone is hydrating. But I actually look at the skin. It's called skin turgor to see how well you're hydrated. You can
Mhm.
also see it in the face, but also your veins, because your veins really tell you about your hydration. And these are things I do in a microsecond. And I can just
Mhm.
look at a patient and say, you're dehydrated, or you may have high blood pressure, or are you here to talk about your cholesterol? And sometimes they're like, oh my God, how did you know? And I'm like, because I can just have
I
been
can
trained to
tell.
see these things.
So I imagine that there are some listeners who are right now looking in the mirror at some of these physical exam signs. Would you recommend that they get on the phone and call your office, or should they call their internal medicine or family medicine doctors? What should they do next?
Yeah. So I always think that, the United States Health Task Force, first of all, says by the time you're 18, you should probably check in, get a general look at yourself. Number 2 is because high blood pressure and diabetes is so prevalent in this country, go see your doctor at a minimum. We call it vitals. So there's something called vitals. Okay, so what are your vitals? Let's start there. Your vitals are your blood pressure. Your vitals are your heart rate, which is also known as your pulse. Your vitals is how much oxygen, so it's called a pulse oximeter,
Mm-hmm.
and as well as your weight. So these are 4 things that I want everyone to really know. We call it know your numbers. And so your blood pressure should not be more than 140 over 80. So 140 reflects your top number known as systolic, 80 reflects your bottom known as diastolic pressure.
Mhm.
So I want everyone to remember 140 over 80, write that down. Go see your doctor, get your blood pressure checked. If it's higher than that, it needs to be addressed and fixed. And that could be from lifestyle choices, losing weight, low sodium diet, and you may need to be on a medication as well. The second number that I want everyone to remember is your pulse rate. It generally, in general, should be between 60 and 80. That is considered normal. Bradycardia, which is a slow heart rate, is typically below 50. Some people define it below 60. And tachycardia, which is a fast rate, is above 100. So yours in general should be between 60 and 80.
While resting, right?
That's right. Great. Thank you for pointing that out. And then your weight, it's people call your basic metabolic index or BMI should be less than 25. If it's above 25, you're overweight. If it's above 30, it's called obesity. And then your pulse oximeter is important. I think people got more aware of it during COVID because people's oxygens were going down.
Mm.
But that should really be maintained above 95%. So these are four numbers, are very basic. The only other number I will think that everyone should know is something called an A1C. It's also known as a hemoglobin A1C, and that's a 3-month average of your sugars should be less than 6.5%. That should be part of pop culture because there's so much diabetes going on
Yeah.
and your sugars. So these are kind of 5 numbers, but no, they can go see their primary care. And if those are out of range, we have a very strict philosophy of really addressing you as a person, understanding your social determinants of health, understand what drives you, because at the end of the day, if you don't have purpose, people don't make changes. So we really try to find out, what is that thing about you? What is that purpose? Why? And
Mhm.
to me, life is why. And so if we want to be the best part of our living, at this point in the present, then it's really knowing those numbers and getting those under control.
Yeah. So you talked about at age 18, every individual is recommended to start getting their blood work checked, including cholesterol. Are you aware that now 11-year-olds are recommended to get an LDL cholesterol, every 11-year-old, not based on risk factors or BMI?
Yeah, so it's amazing. And the reason is because we want to address lifestyle choices early. It's not about putting people on statins, guys. It's about like understanding where your drivers for heart disease, cholesterol being one of them. And because there's a lot of so that's family history of heart disease, especially those patients need to be seen very early. So it's not a surprise that the pediatric societies are saying, let's address this way, way, way early. Why am I going to wait for someone to have a heart attack and then
Right.
start talking about prevention? Let's start making those lifestyle choices as kids. By the way, if you remember when we were growing up, we were doing the presidential, there was like this, the president of the United States had a task force that said, let's get kids exercising. Exercise was like a big part of our growing up.
Yeah.
And we've gone away from that. And so what I think the pendulum shifted way too far about, like, we're not exercising, we're adding more to these kids. There's more
Mhm.
stress on these kids.
Mhm.
There's more social media with these kids, and there's less exercise, and there's more mental health issues as a
Mhm.
consequence. Obesity and being overweight is a big driver. Sleep apnea is a big driver. And so we're becoming more stressed.
Mm.
And with stress becomes stress eating, and with stress eating becomes obesity, and with obesity comes hypertension and diabetes. And then it's a downward cycle.
Yeah.
So getting ahead of that early, even in an 11-year-old, and saying, you know what, let's have better lifestyle choices. Why don't we eat some vegetables? Why don't we talk about doing some exercise? Why don't you get out and play outside in the streets and get on your bike or do some walking?
That's wonderful, especially at an age where you're still impressionable. So these can be set up as life habits when you get started early like
I
that.
love what you said. It's not medications. It's life habits. We say lifestyle as medicine. It's not medication, medication, medication. It's first starting with the why. And that's
Mhm.
how you started this podcast, was what is the cause? It's about fixing the cause and having purpose behind that cause. and then creating a shared decision pathway. And
Right.
that's a really important word. It is a shared decision. Me as a clinician should be talking to you and understanding your beliefs, your systems, your processes, and your why and your purpose. And then creating a treatment plan that's based on a shared decision. I should be telling you all of your options, but understanding with a filter and a framework of who you are.
Yeah.
And I don't think we spend enough time understanding the patients at an individual basis. I think
Mm.
we spend a lot of time on population health rather than personalized health.
Mm.
And I think if we can get down to the personalized health, we can make a better impact because at the end of the day, it is your behavior. If we don't create behavioral changes, we're not going to get the outcomes that we want.
Wonderful. You talked about some of the blood markers as a functional medicine doctor who takes an integrative approach. So I'm bringing conventional practices and some out of the box practices. We definitely order all of those markers, LDL cholesterol and hemoglobin A1C and many others. But we go a step further and we're regularly getting markers like fasting insulin and LP little lipoprotein A and lipoprotein PLA or PLA2.
Mm.
What do you think of the utility of these other markers?
You're addressing a really important topic, which is heart disease is not all about your LDL.
Mm,
That is a very important part. Understand that 50% Americans who die of a heart attack had a normal LDL.
mm,
Okay. But inflammation, it's
mm,
inflammation, inflammation, inflammation. So we look at biomarkers like myeloperoxidase. We look at biomarkers like LPPLA2. We look at biomarkers like HSCRP,
mhm,
C-reactive protein. This is inflammation, and this is not up for debate. Inflammation, oxidation, being under an oxidative state means being under an inflammatory state, and inflammation in the heart and heart disease don't go well. You also pulled up some other biomarkers that which may be a little bit technical, but it's important for everyone to write down ApoA, ApoB. These are called lipoproteins, and a very important particle, which is one of the most atherogenic, which means it causes the most heart disease, called LP little a. And that we find in 25% of the population. That
mm,
particle, LP little a, is that particle that if you ask you definitely have a family history of heart disease, you want to get that checked out.
mhm.
Because if you have that LP little a, which 25% of the population has, you're more at risk of a heart attack earlier than people who do not have that particular particle. But these are what we call advanced lipid testing, which are becoming more and more of the norm. I've been doing them for 10 years, and I've been doing it when we didn't even have a treatment. Why?
Mm,
People said, why are you checking for LP little a when there's not a treatment for it? Because then I can motivate my patients to do all the other
yeah.
things to improve their lifestyle, eat lower carb or, eat lower sugar because carbs and sugar equal inflammation.
Mm,
Your diet, your exercise, your stress levels, your lack of sleep, sleep apnea, these are all pro-oxidant. They make you under inflammation. And so what we want to do as much as possible is live a anti-inflammatory, antioxidant life. And
mhm.
those biomarkers that you just talked about and I talked about are markers that we can see what is your level of inflammation, and then we can start addressing those inflammatory markers.
Dr. Mark Hyman, a prominent functional medicine doctor, has given a great metaphor that I use regularly with my patients, which is think of cholesterol as dynamite. You can put dynamite away in storage and it's not going to hurt anything, but you come around with a lit match and that dynamite can be a huge issue. And so your cholesterol is the dynamite and the lit match is inflammation. So, I tell my patients regularly that we need to look for that inflammation to know how aggressive we need to be with treating your cholesterol.
And it really is a dynamite because I will tell you, I lost my best friend about 2 years ago from a sudden cardiac death. And when we looked at the statistics, 50% of Americans who have a heart attack, the first incident is without any symptoms. It just happens.
Mm,
And that is what's called sudden cardiac death. And so it's important to point out, even on this podcast, that those patients who had a sudden cardiac death had what's called a ruptured plaque. And that is what you just talked about, the dynamite that gets lit,
mm,
that inflammation. When you have a stable plaque in your heart that becomes an unstable plaque, then creates a heart attack. And the first presenting symptom can be death. And that's
mm.
exactly what happened to my best friend. And since the last 2 years, I've always been a preventative cardiologist, but I'm now very interested in how can we use technologies to figure out who's at risk. And the way I look at it is three simple areas or three buckets. And I talk about anatomy, physiology, and serology. So I'll just briefly talk about that. Anatomy means, do you have a heart blockage in your heart? And there's things that you can look at, like a ultrasound of your heart, also known as an echocardiogram. And you can look at something called a coronary artery calcium score, also known as a CAC, which is a CT scan of your heart that can see if you have calcium built up in your arteries that can indicate whether you have a plaque or not. And then there's even one more where you can shoot dye in the arteries, and that's called a CTA, which stands for a CT angiogram of the arteries of the heart. And then physiology, the second vertical, is your heart under stress. And that's what we call a stress test. So you've
Mhm.
heard people run on a treadmill and we check your heart. And so that's a second kind of bucket. And then the third bucket is serology, which is exactly what we just talked about. What are all of the blood markers that you could look at, including your total cholesterol, your LDL, which is your bad cholesterol, your HDL is your good cholesterol, and your triglycerides, which is a reflection of something called triglycerides, which is fat essentially in your blood. And then we can do some of these more advanced lipid testing that can even tell us a little bit more about the cause if you have plaque or not. So these are three sort of verticals that I would tell people to think about: the anatomy, your physiology, and then the blood work, and put that together. That creates a profile about your risk.
Wonderful. I have a lot of patients who come to me asking for a coronary artery calcium score, as well as asking if they should get a CTA or an MRA, an MRI where you inject dye into the arteries. What do you say is the best of those imaging modalities?
So we know, I'll just touch upon very quickly, a coronary artery calcium score is often called a heart scan. It's a quick, non-invasive CT scan. There is no dye, there's no contrast, and many imaging centers do it. In general, it goes from 0 to 400. 0 means low risk, 400 means high risk. Unfortunately, what we found is a percentage of patients, more than 40%, can have a calcium score of 0 and still have plaque in their heart. So let me make sure we
Mm,
differentiate. There's two types of plaques in your heart. There's soft plaque, which is the one we think about cholesterol getting oxidized. And then there's something called hard plaque, which is known as calcium. But hard plaque really represents a scar. And if you have soft plaque that hasn't scarred yet, you may miss a patient with a calcium score of 0. That has happened many times. I've been able to catch them in my clinic. But so there's not really a best imaging. There is what we call appropriate imaging. And those appropriate imaging are really for patients who are at risk. So as a whole, when we talk about your heart, and as a heart doctor, my job is to tell you your risk. I'm a risk stratifier. I either put you at a low risk, I put you at an intermediate or a moderate risk, or I put you at a high risk. So my job in those three buckets, anatomy, physiology, and your blood work, I have to create a risk profile. And based on that risk profile, I then send you for a CT scan of your heart. That could be a calcium score, or it could be a CT scan with contrast, or it could be a stress test. But as a whole, stress tests, exercise stress tests as a whole are not specific enough to really tell me if you have heart disease or not. It is I always tell patients I have to keep you alive long enough for technology to catch up. We're at an era now where technologies has caught up, including using artificial intelligence on top of these scans that we're talking about. So as a minimum, to answer your question, I would go get a calcium score because it gives you at least a general wide net to tell me your risk. I would get in, I would get your vitals, your
Hmm.
blood pressure, your heart rate, your oxygen status, and your weight. I would get an EKG that looks at the electrical part of your heart. These are really the minimum. And then we can really start diving into more preventative and more risk stratification. Because at the
Hmm.
end of the day, none of us have no risk. We're all at risk. It just depends how high of a risk profile you have. And all we really do is we collect information to tell you where you are in that risk stratification. And here's the great news: we can always de risk you. We can take a
Mm.
high risk patient and with the right tools, bring you down to a moderate, or even I've even seen reversal of heart disease down to a low risk.
Amazing. That was very insightful. I've been kind of low key bragging that my calcium artery score was 0, but now here I find out that there could be more to the picture. So you can't
It's a little
stop
bit of
there.
a sucker punch.
Mm.
And I will just warn that the new data that came out, the American Heart Association and the American College of Cardiology, so these are not my opinions, showed data around even calcium scores of 0 um, can still be at risk because you may have not calcified your arteries and you may have not had enough time to do that. So you could still have soft plaque.
Mm.
And that there are other tests like a CTA that can be done.
Okay. You are obviously very passionate about cardiology. Where does that come from? What inspired you?
I was very fortunate to have a great mentor, and mentors can mean the world. I'll tell you very quickly, when I was in 8th grade, I did a talk on ultrasound of the heart, and my teacher thought my dad did
Wow.
him. So FYI, my dad's a cardiologist.
Hmm.
He trained under Dr. DeBakey and Dr. Cooley. They
Wow.
were the first heart transplant surgeons in the world. And I grew up under the shadows going to Dr. Denton Cooley's ranch. I was very fortunate as a first year medical student. I walked into an elevator at midnight, about to go take a test at 8 in the morning. I was finishing studying, and a Nobel laureate named Dr. Fried Murad, who won the Nobel laureate in nitric oxide, said, "Do you know who I am?" And I said, "Yes, I know who you are. Like, the building's named after you. Like, you're the guru in nitric oxide and heart disease." And he said, "Come and meet me in my office." And you take the meeting when a Nobel laureate
Of
at
course.
midnight says, "Come and meet with me." And he challenged me at that day. And he said, "What are you doing in life?" And ultimately, what he said is, "Asif, go get a master's in public health, understand population health, understand public benefit companies, and go out and do something bigger than just yourself and really give back to society and make sure that you understand and you give education awareness to the masses so that they can be empowered to make the right decisions in their lifestyle."
Amazing.
Yeah.
Well, yeah, when you hear words like that of inspiration from a Nobel laureate, you take it.
And I had to honor his request, and I hope I've done a good job with that.
It looks like it. But you've spoken at the Functional Forum about postural tachycardia syndrome, a condition that's often mistaken for heart disease or just totally misunderstood. For clinicians and patients alike, how can POTS be distinguished from structural cardiac issues?
It's a great question. So I want to frame it this way. The reason most patients, so there's a condition called POTS. So I think it's important to define it. It is called postural orthostatic tachycardia syndrome. So postural just means going from lying to standing. So when you stand up, in certain individuals, they feel very dizzy, like they're about to pass out.
Hmm.
So what do? They go back and lay down, which is the worst thing they can do because they become more
Hmm.
deconditioned. So individuals here listening to this podcast, if you're laying down and you stand up and you feel dizzy, you feel like you're going to faint, what's happening is you're not getting enough blood flow to the brain. And so your body says, "Let me make you go flat so you get enough blood flow to the brain." Because when you lay down, you're getting enough blood flow. It's really a blood flow issue to the brain, and your brain saying, "Hey, I'm going to make you feel dizzy so you go back down laying down."
Hmm.
So if you're not getting enough blood flow to your brain, what is your heart going to do? The heart rate's going to go up to circulate more blood flow to your brain. So it's more kind of the chicken and the egg. So most patients show up to the doctor because your heart rate's going crazy.
Hmm.
It's like every time I stand up, my heart rate shoots up to like 120 or even more. And so we as cardiologists see these individuals. These individuals, 95% are female,
Mm.
and most are between 50% or less than 18 and 15% are greater than 18. But the issue with POTS is you're not dropping your blood pressure, your heart rate is inappropriately going up.
Mm-hmm.
And so that's why cardiologists end up seeing those patients. And it's not a structural heart issue, it's more of an issue of your body adapting to a postural change that makes your heart rate go up. And so it's really the cardiologists are usually the entry point. They might put a heart monitor on you. They may check an EKG and say, yeah, your heart rates are really, really inappropriately shooting up. And then there's a whole nother podcast we'll have to do on
You're
POTS because
right.
I could talk to you an hour about POTS. But that's, I think it's important for people just to know that there is a condition. A lot of tell the patients it's anxiety. It's not anxiety. It's a real medical condition. So if you're feeling anxious every time you stand up or your heart
Mm.
rate shoots up and you feel dizzy and your body makes you go back down and then you feel more fatigued and you feel very anxious, it's something that you may want to look at.
All right. And I know the last time I heard you talk about it, you suggested that the orthostatic part, the O in POTS, may or may not, may be a misnomer. It might not, you're not dropping your blood pressure. So I didn't know if I should call it POTS or PTS or what we're calling.
You're great, and you're very right. And even the new CPT code that came out in 2022, it was CPT code G90.A, actually in the definition removed orthostatic. So just so the people listening, orthostatic hypotension means a drop of blood pressure by 20 millimeters of mercury. That doesn't happen in POTS patients. We know when we do a tilt table test and we make patients go from lying to standing, the heart rates shoot up within 10 minutes of a 30 beats per minute or above 120. That's the strict definition. With feeling like you're going to pass out, that's called orthostatic intolerance. And that is the definition of POTS. And so when you laid them back down, the heart rates come back down. The blood pressure really never changed. And so that's why we say should remove the word orthostatic and just call it postural tachycardia syndrome.
And then I also find it a little difficult for a patient to recognize if this is happening with them because also dehydration can cause that. So then I guess you have to make sure you're well hydrated and then see if it happens.
Yeah, so that's absolutely correct. So there's many causes of POTS. One is hypovolemia, and there's so many more, by the way. Many things that cause, for example, inflammation can also cause POTS, autonomic disorders as well, and then even autoimmune disorders. So we don't want to just call it hydration, but you're 100% correct. The first thing we look at is hydration. That's why when you said when you go into a room, what is some of the things you look at? I look at their veins to see if they're hydrated or not.
Okay. Excellent. In closing, I would love to hear your honest opinion. Do you think we'll ever see a significant shift in heart disease rates in the U.S.?
Absolutely. So we did see that since the 1960s, actually a precipitous drop. Problem is now we're seeing a rebound up and mainly driven by many of the things we talked about today, health inequities, lack of access to good health care, cardiology deserts, social determinants of health, your zip code, many, many different factors. And so I think one of the things that the American Heart Association pushed out exactly about that question, what can we do about it? So it's like, yes, we're having an uptick of heart disease. We had a really good reduction because of medications that have come out, but what can we do now? So that is called life essential aid. So I'd love to at least conclude on life essential aid. So this is the American Heart Association, and these are areas that everyone can do to improve their cardiovascular health. So these are the 8. One is to eat better, to focus on balanced whole food diets. Just emphasizing on fruits, vegetables, and lean proteins and whole grains. Number 2, be more active. Sitting is the new smoking. Get up and walk. You know, you see those trackers that say 10,000 steps. In fact, for women in postmenopause, it's around 7,500 steps. So don't get so into how many steps I'm taking. Try to get at least 150 minutes per week. Number 3, if you're a smoker, quit tobacco. It is one of the biggest reversible agents for heart disease. Number 4 is get healthier sleep. You need at least 7 to 9 hours. Number 5 is to manage your weight. We talked about BMIs of 25, really making sure that your waist circumference really gets down to a BMI of less than 25. And then control your cholesterol. I think we talked about focusing on the LDL, but also focusing on some of the other secondary factors that we talked about. And then maintaining your blood sugar, having that sugar diabetes under control. By the way, even the studies that looked at diabetes, pre-diabetics, it showed by doing lifestyle choices, not a medication called metformin actually reduced going on to diabetes. And knowing that what's called an A1C, which is your 3-month average of your sugars, really should be down below 5.7% for optimal health. Diabetes is considered 6.5%. And the last one is to manage your blood pressure. The goal is to keep it at 120/80. I said about earlier, hypertension is defined as 140 over 80 or over 90. So really trying to get your blood pressure as low to 120/80. This is called Life Essential Aid. You can look it up online. It's the American Heart Association.
I love that. And for anyone who feels like that list is overwhelming, I want to point out that a lot of those habits build on one another. If you eat right and you exercise, your blood pressure will come down, your hemoglobin A1C will come down. If you sleep better, your weight will also be positively affected. So it's not an undoable list. It all builds on itself.
And it also reduces inflammation, and it also helps with stress.
Hey,
It's like a
it all works
win-win-win.
together. Yes. Dr. Ali, thank you so much for coming and speaking with me today. I think that our listeners really are able to take away, just as we promised in the beginning, some actionable steps that they can put into their lifestyle today.
100%. Thank you so much for having me on. And I just want to tell the listeners, you can really do it and you can make a really big impact on your lives, on your partner's lives, and also on your kids. This is for generational
Yes.
health. This is not just for the individual.
Wonderful. Dr. Ali, where can we find you on social media, online? How can our listeners reach you?
I'm on all of it. The easiest website is HCC Heart. It stands for Houston Cardiology Consultants and Heart. So www.hccheart.com.
Wonderful. Thank you.
Thank you.
Thank you for joining the Dr. Miiko podcast, and we will see you next time.